Hey everyone, and welcome back for another deep dive. Today we're tackling a medical mystery that's surprisingly common. How do doctors decide on blood thinners for patients who already have low platelet counts?
You're right, it's a puzzle that comes up more often than you might think.
And we're talking about anticoagulants for thrombocytopenia here. You sent us some really interesting research on this, so we're going to break it down for you.
Yeah, it's not as simple as it sounds.
So let's start with the basics. For those of us who haven't been to med school, what exactly are thrombocytopenia and anticoagulation, and why are they such a tricky combination?
Okay, so imagine your blood vessels are like a network of pipes.
Okay.
Platelets are like tiny sticky patches that rush to any leaks or damage, clumping together to form a clot and stop the bleeding.
Makes sense.
Now, anticoagulants are like pipe cleaners, medications that help prevent those clots from forming in the first place, keep the blood flowing smoothly.
Okay, that makes sense. But here's where I get confused. If someone has thrombocytopenia, meaning they have fewer of those sticky patches, shouldn't they be less likely to form clots, not more?
That's a great question, and it gets to the heart of this whole medical mystery.
Yeah.
You'd think low platelets would equal low clot risk, but the research you shared throws a wrench in that theory. It turns out that people with thrombocytopenia are still very much at risk for developing blood clots, and those clots can be just as dangerous, even life-threatening.
So it's more complicated than just like counting platelets.
Exactly, it's a balancing act.
Yeah.
Doctors have to weigh the risk of clots, which can lead to serious conditions like venous thromboembolism or VTE.
And for our listeners, what is that?
Basically a clot in a deep vein, often in the legs, which can then travel to the lungs and become a pulmonary embolism, or PE,
Oh, wow.
both very serious situations.
Yeah.
On the other hand, using blood thinners to prevent those clots carries its own risks, especially if someone has low platelets to begin with.
Right.
That's the risk of excessive bleeding.
That's a tough call. It's like choosing between two risky paths.
Yeah.
So how do doctors decide which way to go? What factors are they kind of considering when someone has both thrombocytopenia and a risk of clotting?
It's like piecing together a puzzle, looking at the whole picture.
Right.
Obviously, the platelet count itself is a major factor,
Yeah.
but they also consider the type of clot,
Okay.
how recent it is, and whether it was what we call provoked,
Revokes.
meaning it happened after surgery or an injury, for example,
Yeah.
or unprovoked, which is often a bigger red flag because it suggests an underlying tendency to form clots.
So a spontaneous clot is more concerning than one that happens after a known event.
Exactly.
Okay, that makes sense. Are there other red flags that they look for?
Absolutely. They'll also consider the person's overall health. Older adults tend to be more prone to both clotting and bleeding complications,
Oh, interesting.
and any history of previous clots or bleeding episodes. Even a history of bleeding when their platelet count was normal is a big clue that they might be more susceptible to bleeding on blood thinners.
That's really interesting. So past bleeding, even if their platelets were fine then, is a warning sign.
It can be, yes,
Wow. What about other health conditions? Do those factor in at all?
definitely. Things like liver disease or kidney disease can affect the body's clotting mechanism,
Okay.
increasing the risk of both clots and bleeding. And even something like a high risk of falling becomes important.
Really?
Because if someone is on a blood thinner and more prone to falls, even a minor injury could lead to serious bleeding.
It's amazing how many factors come into play.
It's complex.
So they're looking at the clot itself, the person's overall health, their history. Is there anything else?
There are also inherited blood clotting disorders that can tip the scales, making someone more prone to clotting. Two examples are factor V Leiden and antithrombin deficiency. Don't worry too much about the names. What matters is that these conditions can make the blood more likely to clot. It's like having sticky pipes from birth.
Sticky pipes. Got it. Okay. So they're gathering all this information, weighing the risks and benefits for each individual patient. It sounds like there's no easy answer.
You're right. It's highly individualized medicine. And that's where open communication between the doctor and the patient is absolutely crucial.
Yeah.
Patients need to understand the risks and benefits of each option so they can make informed decisions about their own health.
Absolutely. It's a partnership, not a one-way street, which I love.
Right.
So once they've considered all these factors, what are the different approaches to treating someone with thrombocytopenia who needs anticoagulation? What are their options at that point?
Well, there's a whole toolbox of options, and each one has its place, depending on the situation. One option is full-dose anticoagulation, which is usually the go-to for treating VTE if the platelet count is above a certain level. Think of it as the kind of the standard approach, unless there are reasons to choose a different path.
And what if the platelet count is below that level, but the patient still needs anticoagulation? What then?
That's when things get even more nuanced. Doctors often use a specific algorithm, basically a set of guidelines to help them make decisions in those tougher cases.
Okay, let's unpack that algorithm. What does it take into account? And just how tricky do things get?
That's a great lead-in to the next part of our deep dive. Buckle up, because we're about to explore those trickier scenarios, starting with one of the biggest challenges of all, cancer.
All right, so we're talking about this complex world of blood thinners and low platelets,
Right.
and now we're going to add cancer into the mix. That's got to be like playing medical Jenga. One wrong move and things could get messy.
That's a great way to put it. Cancer really does throw a wrench in the works. It's fascinating, actually. Cancer cells are like these little troublemakers,
Yeah.
disrupting the body's delicate balance in all sorts of ways.
Right.
One way they do that is by releasing substances that make the blood more likely to clot. But at the same time, cancer treatments like chemotherapy can actually suppress the bone marrow's ability to produce platelets.
So it's like a double whammy. Cancer makes you more prone to clots, and the treatments can lower your platelet count even further.
Exactly. It's like walking a tightrope between two potential dangers.
Right.
Dangerous clots on one side and serious bleeding on the other.
No wonder doctors need an algorithm to help them navigate this. You mentioned it earlier. So when we're talking about cancer patients with thrombocytopenia who need anticoagulation, what are some of the key things this algorithm takes into account?
One of the first things it considers is the acuity of the blood clot, how recently it formed. If it's a brand new clot, say within the past month,
Okay.
the risk of it growing or breaking off and causing trouble is much higher.
So newer clots equal higher risk. What about the size and location of the clot? Does that matter?
Absolutely. A large clot in a major vein, like a deep vein thrombosis or DVT in the leg,
Okay.
that's a bigger concern than a smaller, more superficial clot. And the location matters too. A clot that's close to a vital organ is obviously riskier than one that's farther away.
So bigger, newer clots, closer to vital organs, those are all red flags. What else does this algorithm factor in? It also looks at the patient's overall health and functional status. Someone who is very weak or bedridden, for example,
Right.
might be at higher risk for both clotting and bleeding complications because they're less mobile
Yeah.
and their blood is more likely to pool. And then, of course, there are those other bleeding risk factors we talked about earlier.
Right.
Age, history of bleeding, other health conditions, those all get factored into the equation.
It's a lot to consider. So this algorithm is a helpful tool, but it sounds like there's still a lot of judgment involved. Are there certain types of cancer that make this whole situation even trickier than others?
You're right. It's not just plug and play.
Right.
Doctors have to use their judgment and experience to interpret the algorithm's recommendations for each individual patient. And yes, some cancers do present unique challenges. For example, brain tumors are particularly concerning. Yeah.
Because they increase the risk of bleeding in the brain,
Right.
which can have devastating consequences.
So it's a very delicate balance between preventing clots and avoiding a brain bleed.
Yeah,
That's got to be a tough one for doctors to navigate.
it is.
What about other types of cancer? You mentioned multiple myeloma earlier.
Yeah, multiple myeloma is another one that often requires a very individualized approach.
Okay.
It's a type of blood cancer that affects the bone marrow, which, as we know, is where platelets are made.
Right.
So patients with multiple myeloma are already at increased risk for thrombocytopenia, but on top of that, the disease itself
Right.
and some of the treatments for it can also make the blood more likely to clot.
It's like a perfect storm of clotting and bleeding risks.
Exactly.
Oh, wow.
Yeah. So with cancers like these, doctors have to be extra cautious,
Right.
monitoring patients closely for any signs of trouble and adjusting treatment plans accordingly.
It's a good reminder that cancer isn't just one disease, but a whole spectrum of diseases,
Absolutely.
each with its own, quirks and challenges.
Yeah.
We've talked a lot about cancer, but what about other situations where someone might have both a low platelet count and a need for anticoagulation? What else does the research highlight?
Well, one common scenario is liver disease.
Okay.
Just like cancer can disrupt the body's clotting system, liver disease can do the same. And when the liver isn't functioning properly,
Right.
it can increase the risk of both clotting and bleeding complications.
So it's not as straightforward as liver makes clotting factors, liver disease means less clotting.
Right. It's more about A broader disruption of the body's delicate balance, a state the research calls rebalance hemostasis,
Okay.
and that can make anticoagulation tricky.
Fascinating. What other situations should we be aware of?
Another common one is atrial fibrillation, or AFib for
So
short.
that's a heart rhythm disorder, right?
Exactly, and it significantly increases the risk of stroke.
Right.
Anticoagulation is often a cornerstone of treatment for AFib, but if a patient also has thrombocytopenia,
Right.
finding the right type and dose of blood thinner becomes even more critical
Yeah.
to prevent a stroke without causing a major bleeding event.
So it's all about finding that sweet spot,
Yes.
minimizing one risk without increasing the other.
Right.
Are there any other common scenarios where these two issues kind of collide?
Yes, acute coronary syndromes, basically,
Yeah,
heart
yeah.
attacks, often require a careful balancing act as well. These are usually treated with a combination of antiplatelet medications and anticoagulants to prevent further clotting.
Mhm.
But if thrombocytopenia is present,
Yeah.
doctors have to adjust that approach very carefully.
Right. Right. It always circles back to that, like weighing the risks and benefits for each individual.
It does.
Now, we've covered a lot of ground here: cancer, liver disease, AFib, heart attacks, all situations where doctors might need to use blood thinners in patients with low platelets. Is there anything else our listeners should know about this complex interplay? Anything that might surprise them?
There is one more layer of complexity that's important to understand.
Okay.
There are actually some conditions that can cause both thrombocytopenia and deep blood clots simultaneously.
Wait, so it's not always one or the other. You can have both problems at the same time. That's wild. Tell me more about these like double whammy conditions. So you're telling me that some conditions can like throw the body's clotting system completely out of whack,
It really is, yeah.
leading to both a higher risk of clots and a low platelet count at the same time.
At the same time.
It's like the worst of both worlds.
It is, and it makes managing these patients incredibly complex.
Yeah,
Imagine trying to put out a fire while someone's shutting off the water supply.
right.
That's kind of what it's like. These conditions require a very delicate balancing act
Mm-hmm.
and often involve specialized treatments.
Okay, so what are some examples of these conditions that cause this, like this double whammy?
One example is antiphospholipid syndrome, or APS.
Hmm.
It's an autoimmune disorder, which means the body's immune system mistakenly attacks its own tissues.
Right.
In APS, the immune system produces antibodies that can actually promote clotting,
Oh, wow.
increasing the risk of dangerous blood clots, but it can also lead to low platelet counts.
Oh, wow. So it's like the immune system is playing both sides of the field,
Yeah,
causing problems on both ends.
exactly.
What are some other examples?
Another one is heparin-induced thrombocytopenia, or HIT. This one is particularly interesting because it's actually a reaction to a medication, heparin, which is a commonly used blood thinner.
Wait, so a blood thinner can actually trigger clotting? That seems counterintuitive.
It does, doesn't it?
Mm.
But in HIT, the body forms antibodies that activate platelets, leading to both clotting and a drop in platelet count. It's a rare but serious complication that requires immediate attention.
That sounds pretty intense. Are there any other conditions on this, like double whammy list?
Yes, one more I want to mention is paroxysmal nocturnal hemoglobinuria, or PNH for short.
Okay.
It's a very rare blood disorder that can cause a whole cascade of problems, including the breakdown of red blood cells, leading to anemia, and sometimes a decrease in platelets as well. And to make matters worse, it can also increase the risk of blood clots.
So with these conditions, it's not just about managing the clotting risk or the low platelet count. It's about addressing the underlying disease itself.
Exactly, and that often involves specialized treatments that are tailored to the specific condition. It's a team effort, often involving hematologists, doctors who specialize in blood disorders, to manage both the clotting and bleeding risks effectively.
It sounds like a real medical minefield navigating all of that.
It can be, but the good news is that doctors have a lot more tools in their arsenal these days to manage these complex situations.
Right.
We've talked a lot about different types of anticoagulants, but there are other options as well. For example, platelet transfusions can be a lifesaver when someone with severe thrombocytopenia needs anticoagulation but has a very low platelet count.
That makes sense. It's like giving them an emergency delivery of those sticky patches we talked about earlier.
Exactly.
But you mentioned something earlier about transfusions not always being like a perfect solution. Can you elaborate on that?
You're right. Transfusions aren't a cure-all.
Right.
They're very effective in many cases, but their effectiveness can actually vary depending on the underlying cause of the thrombocytopenia.
So what you're saying is sometimes those sticky patches don't stick around as long as we'd like them to?
Precisely. If the thrombocytopenia is caused by something like an autoimmune disorder, where the body's destroying its own platelets, a transfusion might provide a temporary boost.
Okay.
But those new platelets might get destroyed as well. It's like trying to fill a leaky bucket. You can keep pouring in water, but it won't stay full unless you fix the leak.
That's a great analogy. So in those cases, what's the solution?
That's where those other treatment options we've discussed come into play, things like temporarily holding anticoagulation, using reduced doses, or addressing the root cause of the thrombocytopenia, if possible.
It all comes back to that individualized approach, finding the right strategy for each patient's unique situation.
Exactly. And speaking of individualized approaches, there's one more treatment option I wanted to mention. Thrombopoietin receptor agonists, or TPORAs.
Those are a mouthful. What are they and how do they work?
Think of them like platelet factories in a pill.
Okay.
Thrombopoietin is a hormone that stimulates the production of platelets.
Okay.
And TPORAs basically mimic its action. They essentially give the bone marrow a nudge, telling it to ramp up platelet production.
So rather than just giving someone like a one-time delivery of platelets through a transfusion, TPORAs help the body make more of its own platelets.
That's a great way to put it. They're not a quick fix like a transfusion, but they can be a valuable tool in certain cases, like immune thrombocytopenia, where the body is destroying its own platelets.
It's like giving the bone marrow a pep talk, like, come on, team, we need more sticky patches.
Exactly, and that highlights an important point. We have a whole toolbox of treatment options available these days.
Yeah.
From different types of anticoagulants to platelet transfusions to medications like TPORAs. And the key is to carefully select the right tools for each individual patient based on their specific situation and risk factors.
It's like being a medical mechanic.
Yeah,
Figuring out what's wrong and then using the right tools to fix it.
I like that analogy. Sometimes it takes a single tool, and sometimes it takes a combination of tools to get the job done.
So we've covered a lot of ground in this deep dive. The basics of thrombocytopenia and anticoagulation, the challenges of managing patients who need both, the added complexities of cancer and other medical conditions, and even those rare disorders that cause both problems simultaneously. I feel like I've learned a ton, but the biggest takeaway for me is just how individualized this whole process is.
I agree. That's a crucial point. There's no one-size-fits-all approach. It's about doctors and patients working together,
Yeah.
gathering all the pieces of the puzzle and coming up with a treatment plan that makes sense for that individual person.
It's about open communication, shared decision-making, and a whole lot of careful consideration.
Absolutely, and I think that's a great note to end on. If there's one thing our listeners take away from this deep dive, I hope it's that knowledge is power.
Yes.
The more you understand about your own health, the better equipped you are to have those important conversations with your healthcare providers and make informed decisions.
Well said. A huge thank you to our expert for guiding us through this complex and often confusing world of blood clotting and platelet disorders.
It was my pleasure.
And to our listeners, thank you for joining us on this deep dive. We'll see you next time for another fascinating exploration into the world of science and medicine. Until then, stay curious.